Okay, good afternoon. Happy Friday. For some of you, happy spring break, all that good stuff. Um, Wanted to welcome you to the Mental Health Parity Advisory Committee meeting for March. I'm going to do a quick roll call to make sure people are here. Angela Gamboa, Carly Fleege, David Carnahan, Dr. Don Fowles.
I'm here. Hey, Lynette.
Good afternoon. Jasmine Snipes, Terry Stevens.
Good afternoon. I'm here.
Good afternoon. Kathy Busby. Monica Curry. Dr. Wilson. And Vista Thompson. Okay. Our meeting will probably be a little short. I do understand some people are on spring break and are out of town enjoying our finally nice weather. Getting out of the house finally after being cooped up for many months, so I do understand that. First thing that we want to talk about is the website. There are not any current updates. We are still receiving information for FAQs and things like that we will be adding sometime this month. But we do want to briefly talk about if anyone has any feedback. Jasmine mentioned it last month on how to disseminate this information to areas that may have don't have internet, can't log on. We want to definitely be inclusionary and respect cultural differences and things like that. And so some of the recommendations that I was given is maybe partnering with schools to help share this information, getting out pamphlets, even possibly doing some seminars at community centers and things like that. But if anyone has any other recommendations, especially like when you're rolling out like a new policy or things like that, that we could use as a process or a protocol to share information about mental health parity, I would love to hear that. Or if you want to email that to me, we want to make sure that we are educating not just the small group, but we are touching the state of Arizona as a whole. Any comments, recommendations?
I will say, this is Carrie. I think the schools is a really good idea. I know that when we've done statewide changes for some of the health plan information, we partnered with the schools, and many of them had different community forums, and with our provider community too. They are usually very well connected. So I don't know if that is an option, but our behavioral health provider community are usually very well connected in the communities that they're in, and so that may be, they have different committees and family education nights and kind of forums and whatnot, and that may be an opportunity that we could leverage.
Thank you. And when you do those, are you handing out like a hard copy informational packet for people that may not have access to the internet?
Typically what we've done is try to do community forums to provide education, and so we leverage the schools and our providers to get the information to families to invite them to the community forums. But we could do it a multitude of ways. That I'm not suggesting that we have to do community forums, but it could be, we could definitely ask them to hang some other ideas and things that we've done throughout the years is ask people to hang things in the lobby, even with that web, with the website. And, if they have the space in the lobby, many, want to help get the information to families. Our family runs are another really, like Family Involvement Center. My Kid is statewide. And we could make sure that we educate basically the frontline staff that are out there connecting with families so that they could share that information. If there is a brochure or pamphlet, or, we could certainly give them a hard copy, but I don't know that that's even necessary. I think, if we have a couple of different methods and get them to the right people that are out in the community or where the community is accessing, like I said, some of the lobbies of our behavioral health homes and whatnot, I think eventually we'd have to target it in a couple of different kind of streams, but I don't think any one of those methods would be wrong.
Thank you. I know as well, we need to look at having it in translated into some other languages as well as we disseminate the information to make sure that's accurate as well. So I will thank you for that feedback. Anyone else?
Oh, Lynette, this is Don, and I think just a related thing is, just how to get the word out to the, the medical community as well. And, using the ARMA, the local medical association organizations like that to get information out to, and even get into their, the doctor's offices, since that's where a lot of people are getting behavioral health services, actually.
Sure.
Yeah, and Dr. Fowles, to even build on that, our ASOs, like if we partner with, if we connect with our equalities or those that are connected to the PCP offices, you're absolutely right. That's, a great source of kind of connecting the community to information.
I like both of those ideas, and you're right, Dr. Fowles, people are going to their PCPs for behavioral health more so, and with the integration, you see that more too, so that would definitely be a good touch area. Anything else? Suggestions?
I think the only other one, this might be a little tougher, maybe a little too ambitious or whatever, but, I think the, coming from the health plan perspective too, of, network providers distributing through those channels in some way, because there's access to huge numbers of providers, the medical, behavioral, et cetera. And, we'd obviously need to, get their involvement, but I know, it'd be interesting to hear Dr. Wilson's thoughts on something like that too, because they have access to huge numbers of providers. And I think one added benefit is not just parity, but it's also knocking down the stigma some too.
Absolutely. Any other feedback on how we get the word out to areas where people may not be able just to have internet or things like that?
Dr. Hannigan?
Yes, ma'am.
Yeah, this is Kathy Busby. Sorry I didn't get on till late. Could you just tell me briefly what we're talking about?
So on the website, it was brought up last month that Jasmine brought it up, and how do we make the website, the information there more inclusionary, and that we are honoring cultural competencies and differences. So getting to the areas where people may not have access to get onto the state website. How do we educate them about mental health parity and the resources and things the information that we're putting on the website? How do we get that outside of just the internet and the web platform?
Okay, get it. Sorry, I didn't have to redo the whole discussion, but thank you.
That's okay. Any feedback or recommendations on that?
Well, I agree when I heard, I think what Don was saying, that working through providers, I mean, I know in particular, like at the Arizona Council, we have a lot of large behavioral health agencies. And so We have a lot of reach with a lot of people across the state, even including some of those areas. So it could be a message that we could deliver through some of those networks, and Dawn's point too, even through other health plans and things.
They know how to do that well, so we can take some cues from them. Thank you, Dana. Any other feedback or questions on that particular topic? Okay. The only other update on the website is we have posted the agenda for the public hearing, which will happen on this coming Monday, the 22nd. There was a little hiccup last week, so it will be Monday, the 22nd. The agenda is on the website under the public hearing tab, as well as if you have questions for Mary Kaczynski, or if you want to still submit public comments, you can do that all from the website. And it's probably a good segue. I'll skip down to number 4, since we're talking about the public hearing. Any questions about the public hearing, the rules, from Mary or myself? No? And we've received some of the public comments, so just want to emphasize, you can share with your networks, or if you haven't had a chance, public comment is still open until Sunday at 11:59. So if you still want to make comments.
Lynette, this is Mary Kaczynski. I got a question about when we are going to post the public comments on our website. And I think we can post whatever we have at this point, if people would like to read them, in order to, maybe file their own public comments on Monday. But I thought maybe I'd bring that up as to the timing of posting them. I don't see any reason why we can't post them. They are public comments. So, and we have about, I think, around 6 or 7 public comments. One of them is very lengthy from one of the law firms on behalf of the insurers, but most of them are, reasonable in length. So I don't know if the committee wants to talk about that, or, decide, when we should consider posting the comments we've received on the website. Obviously, it won't be all of them, because the public comment period will be open until midnight of Monday, but just want to know if anyone has any preference on that.
Have any preference, comments to what Mary is saying? Okay, I can work with, I'll work with our IT department and try to get those posted as soon as we can. Any other questions or concerns about the public comment? Okay. I'm gonna go to agenda item number 3. Very excited to have Tim Clement with us as a presentation on the federal parity compliance regulations. There have been some changes he's going to present, and I also want to apologize to Tim because I conferred him and gave him a doctorate and everything. So I didn't mean to do that, but he's very knowledgeable.
Well, it's not so bad. Sometimes people accuse me of being a lawyer, so it's been worse. So
just take it all in. So Tim, at this time, you have the floor.
Okay, well, thank you very much. I appreciate it. Just make sure that I have the right. So can you guys see my slides up on the screen, or are they?
Sorry, Tim, I'm getting them up right now.
Okay. And so just in the interim, for those of you who don't know me, my name is Tim Clement. I'm Director of Legislative Development for the American Psychiatric Association. And what that means is I write state and federal legislation, but also I work very closely with regulators on parity implementation. That includes state insurance departments, state Medicaid agencies, and then also the United States Department of Labor. So what I'm going to do is I'm just going to go through here. I think a lot of you might be aware that there are new federal parity compliance requirements that were that were enacted last year, late last year. So I'll just walk through that, give you a little bit of history on it, the context of how it came to be and why it came to be, and then get a little bit into the weeds, not too deep into the weeds, but a little bit into the weeds in terms of what the requirements are for health insurance issuers in terms of compliance. So with that, I guess we can go to the next slide. Okay, so these new federal requirements, they were enacted on December 27th, 2020, when the president signed the Consolidated Appropriations Act into law, which was a huge monster bill that had a lot of COVID relief, a lot of appropriations provisions in it. It was one of the biggest pieces of federal legislation in recent memory. And then tucked away in a narrow little slot in that bill, in Section 203 of the Division BB, which was the health insurance provisions part of the legislation, which included a lot of stuff related to surprise billing and so forth. But then in that, there was a Section 203 that amended the Mental Health Parity and Addiction Equity Act. That's the federal parity law. And for those of you that don't know, the federal parity law is replicated in 3 places in the United States Code. It's in the tax code, it's in the labor code, and then it's also in the Public Health and Welfare Code, specifically in the Public Health Services Act. And that's the part of the law that enables state insurance departments to enforce the law. So what it did is it added a new compliance section into that Public Health Service Act component. The technical citation is 42 USC 300 GG-26. And it added a new subsection A8 that has some compliance requirements for insurers and group health plans. And I'll get into those requirements in just a little bit, but it's important to note that what this did is it extended these compliance requirements to every state regulated health insurance issuer in the country, including those in Arizona, except for obviously grandfathered plans. So really what it did is it had a dramatic effect of putting across the board these compliance requirements for all 50 states. And then also, and this is for less relevant for our purposes for this discussion, it also applied these compliance requirements to all federally regulated group health plans, which are sometimes known as ERISA plans. And those are the large group plans that self-insure. In other words, they use their own money to pay their health claims, and they might hire an insurance company to administer the benefits. So, and then that's all under federal purview. So we won't get too much into that, but it is important to note that basically every group health plan and every health insurance issuer in America is now responsible for complying with these new compliance requirements, which I will detail in a few minutes. Next slide, please. So just to give a little bit of a background on how this came to be, this is, I think a lot of folks were surprised by these new compliance, and I'll get to some of the, anxiety involved with why some people were sort of shocked by the requirements when they were signed into law. But this actually started all the way back in 2019. In the beginning of 2019 and into the spring, folks worked with Senators Chris Murphy and Bill Cassidy on getting something introduced along with some folks in the House. And what ended up happening was there was something called, it was a bipartisan legislation called the Mental Health Parity Compliance Act, which was HR 3165 and S 1737. And those were introduced in early June of 2019. And in the Senate, Democrat Chris Murphy from Connecticut was a sponsor, and Republican Bill Cassidy from Louisiana was a co-sponsor. And then in the House, it was Representative Katie Porter from California and Gus Bilirakis, a Republican from Florida. So it had a nice bipartisan mix. What was very interesting is very quickly after that was introduced, due to Senator Cassidy's advocacy and work behind the scenes, it got included into this big bipartisan healthcare package known as the Lower Healthcare Costs Act, which was S 1895, and that was sponsored by Senator Lamar Alexander and Patty Murray of Washington. And this was sort of seen as Senator Alexander's legacy piece, because Senator Alexander retired at the end of 2020 from the Senate, which he'd served for many years. And of course, this bipartisan package of healthcare was most well known for the surprise billing provisions, many of which actually did make it into the final Consolidated Appropriations Act. But the big package was introduced, I believe, on June 26th from 2019. Next slide, please. However, as many of you know, Congress is a very slow-moving beast, and there was a winding journey. And of course, a lot of that was related to the other provisions in the Lower Healthcare Costs Act experienced furious debate, very heated debate regarding the surprise billing provisions. I mean, that is a conversation that I'm sure many of you are aware. It's hard to get to a place where you don't make somebody very angry with whatever you're doing in terms of surprise billing. However, the parity language was not particularly controversial. In fact, it wasn't controversial at all and didn't experience any real pushback from any stakeholders, including the insurance industry. And I do know that the insurance industry did have a chance to make some minor edits to the bill, which they did. But really, that was the parity provisions that were out of the fire. It was all the other things within that bill that made it very controversial. And as 2019 wore on and compromise grew tougher and tougher with the Lower Healthcare Costs Act, and as revisions were made, at the very end of 2019 to early 2020, two key committees in the House and the Senate on a bipartisan basis came to agreement on the parity compliance language, the very, very minor tweaks to what was in the Mental Health Parity Compliance Act. And that language actually, while it was never released publicly, was basically the basis for what ended up getting signed into law. Now, throughout the spring of 2020, obviously COVID set in, and there was, everything in Congress sort of got redirected in terms of the attention. Initially, key staff in the House and Senate didn't want to take the parity provisions out of the surprise billing package because they wanted to keep that whole package together. However, as it got into the summer and started moving towards the fall, it looked like that surprise billing language, there just wasn't going to be a compromise. So the committees in the Senate and particularly the House decided they should probably look for some other vehicles to potentially get that language moving and through Congress, because by this point, there was key consensus among Senator Cassidy, Senator Murphy, Congresswoman Porter, Congressman Bilirakis, and a few others that they really needed to get something on parity over the finish line, and Senate and House committees agreed. So next slide, please. And so what ended up happening is in July of 2020, the language from the language that the key committees in the House and Senate came to agreement on got reintroduced in the House, and it's called the Strengthening Behavioral Health Parity Act. So if you see anything, printed or in the media about the new parity provisions, you might see it referred to as the Strengthening Behavioral Health Parity Act, which is HR 7539. It's basically the exact same thing as the Mental Health Parity Compliance Act with some very, very minor tweaks. And this was reintroduced with the original sponsors, Katie Porter and Gus Bilirakis, along with Congressman Joe Kennedy, Democrat from Massachusetts, and Congressman Fred Upton, a Republican from Michigan. And this exact language, if you were to go onto congress.gov and look at HR 7539, that's the exact same language that got inserted into the Consolidated Appropriations Act. So if you, instead of reading through a 3,000-page bill, which is the Consolidated Appropriations Act, you can go to that bill, 7539, to actually read the content of what's in the law. Next slide, please. Okay, but enough of a history lesson. Let's talk about the actual specifics of what's in the law, what's changed. So all health insurance issuers and all group health plans that cover mental health or substance use disorder benefits, which is basically everyone pretty much covers mental health and substance use benefits today, must perform comparative analyses about how they design and apply quote unquote non-quantitative treatment limitations. And that's a very complicated term, but what it means obviously are the things like prior authorization, formulary design, provider network design, reimbursement rate setting, geographic restrictions, out-of-network coverage standards. There's many, many, many things that can classify as an NQTL, which is the term of art. And here's the thing that put people into a bit of a state of anxiety about this new law. It said that 45 days after passage of the Consolidated Appropriations Act, which was February 10th, all issuers, and of course group health plans, but all issuers must make these comparative analyses available to the applicable state regulator upon request. So in Arizona, that's DIFI. So that's something that was a pretty aggressive timeline. Now, I don't think too many state regulators are going to start going around asking insurers for these analyses right now, because I don't think that would be, that'd be pretty aggressive. But technically speaking, as of February 10th, if a state regulator, the state insurance department, asks a health insurance issuer for these analyses, they have to hand it over. And of course, there's some other specifications in place for group health plans that are subject to regulation by the Department of Labor, but I'm not going to get into those here because that's not really relevant for the purposes of this working group. But if you are interested in knowing about that or having an explanation of that, I'd be happy to answer your questions offline. My email will be listed at the end. Next slide, please. Okay, so we're going to get a little into the weeds here. Usually I stay out of the weeds when presenting on parity, but this is a parity advisory committee. So I think we're ready here for maybe more of a parity 201 course rather than just parity 101. So here's what these comparative analyses that insurers must perform. Here's what's in them. Here's what the insurer has to do. And keep in mind that the terms that are in the new parity compliance requirements that insurers have to show compliance with, these were terms that already existed in the final regulations for the federal parity law, found at 45 CFR 146.136. So what it does is it basically unbundles those very complicated requirements in the final rules and works them into a stepwise comparative analysis format. So the first thing the issuer must do is identify all plan terms involving the NQTL and all benefits, both medical and surgical and mental health and substance disorder, that the NQTL applies to. So if we're talking, let's say, prior authorization, you have to basically spell out what the prior authorization terms are in the plan, but also identify all of the benefits in each classification of benefits. So that could be inpatient, outpatient, prescription drugs, emergency. There's probably never prior authorization or emergency, but identify what benefits are actually subject to, let's say, prior authorization in that instance. Then you have to identify the factors that determine the NQTL will apply to a benefit. So let's say you're an insurer and you apply prior authorization to substance use disorder services, residential services, because you're concerned about fraud, waste, and abuse that might occur in those facilities. So that's why you do prior authorization. Well, that's a factor. So, and the law, of course, already required that you must use comparable factors. So if you're doing prior authorization for substance use disorder because of fraud, waste, and abuse, but you don't do prior authorization based on fraud, waste, and abuse for medical and surgical, that would likely be a violation. So this would be sort of trying to smoke that out. Then the next step is you have to define any of those factors. So let's say you do prior authorization because of fraud, waste, and abuse. Well, how are you defining what constitutes fraud? How are you defining what constitutes waste? How are you defining what constitutes abuse? And are those terms and definitions, in fact, comparable for medical and behavioral health? So if you have a much more strict standard for what you consider fraud for substance use disorder and mental health than you do for medical, that's probably a definition that wouldn't comply with the law and would be flagged here. And then the fourth step is you got to provide comparative analyses showing that each of the underlying terms in the final rules, and those terms are processes, strategies, evidentiary standards, and factors, you have to show that both as written and in operation, not just the written documentation, but how things happen in operation, are comparable and applied no more stringently, which is the test that already exists in the final rules. And then finally, the last step is the insurer's conclusion as to whether and why it is in fact in compliance and how it's shown that in the previous 4 steps. So among parity nerds in the business, this has been known as the stepwise comparative analysis approach. So if you hear people talk about the stepwise analysis, this was what they were talking about. And that's a nice segue into the next slide, please. While some may have thought this came out of left field, that is actually not the case. This stepwise approach has been in place for a number of years. It was first introduced by some advocates in 2017. But then in 2018, a number of states started passing legislation that codified this stepwise approach into law and required insurers to submit analyses in this stepwise approach. It's almost identical to what was just passed in federal law. And by the end of 2020, both through legislative means and through regulatory means, like the Texas Department of Insurance, the Louisiana Department of Insurance, over 20 states had taken nearly an identical approach to NQTL comparative analyses as was in the Consolidated Appropriations Act that just passed. So in other words, this new federal requirement that's in place that applies to all health insurance issues across America, this was kind of already in place for health insurance issuers in 20 states already. And also, back in 2018, the United States Department of Labor put basically the identical approach to what just got signed into federal law in their self-compliance tool, and it was updated in their 2020 version. And then just for those of you in the industry that might have to deal with the Department of Labor sometimes, please be advised that they are taking the mindset that this is not new and that people should have already known about this. So that they're going to be taking a somewhat aggressive posture on this. That's just something I've heard. So anyway, the point here is the Consolidated Appropriations Act, while a new federal set of requirements, it was just it was codifying this growing consensus for what the standard should be for comparative analyses for non-quantitative treatment limitations. And very fortuitously, just last month, I believe, might have even been earlier this month, but I think it was still February, the Texas Department of Insurance, they've created a new spreadsheet that is designed specifically to collect the analyses in this new federal format. So they did some really great work, and they were building on a spreadsheet that was first created by the Pennsylvania Insurance Department back in 2019. That's very similar. It just, the new Texas tool is compressed to the right number of steps for issuers to submit the analyses. So I think that that's something that's very good news, is that you've got folks out there that have created good tools for collecting this information that now, of course, all health insurance issuers have to do these analyses. So it's good that there's already tools out there that folks can look to build on, implement, copy, whatever there may be for collecting the analyses. So with that, I'll just move to the very last slide. So if you're interested in more information, want to reach out, have any questions, please contact me. My email address is there on the screen. That's tclement@psych.org. And with that, I will turn it back over.
Tim, this is Mary Kaczynski. Could you recite that site again to the federal reg?
Sure. So the new federal requirements are found at 42 USC 300 GG-26, subsection A8. Now, if you go look on the United States Code, I don't think they've updated their website yet to incorporate the new language, but it did take effect in December. And then the federal federal regulations, of course, are 45 CFR 146.136.
Thank you.
Those have been in effect since 2013.
Great, thank you.
Lynette, I think you were on mute.
Sorry. Any other questions for Tim? I know everybody's soaking in the information.
Tim, are we permitted to circulate these slides to the committee?
Oh yes, absolutely. Please do. And there's in the slides, there's hyperlinks to all the pieces of legislation that were mentioned.
This is done. While everyone's thinking about this or considering it, I just wanted to put in kudos for Tim. He's been enormously helpful over the last couple, 3 years here in Arizona and nationwide, actually. But and really just providing information and insights into the parity law for anyone who is interested, and that includes, you know, providers, legislators, governor's office, health plans. And my own view is that you've been a pretty, while you definitely believe and advocate for parity, you're pretty neutral in terms of picking sides or anything like that. You just want to do what's, you know, expected of the law, and to help others, you know, figure out ways to comply and you know, just make things better. So I think you've been a really positive influence. And you know, I probably going out a little bit on a limb, but you've been pretty available to anyone who wants to talk about this too. So we really appreciate that, and appreciate your being here today.
Oh, thank you, Dr. Fowles. And yeah, and I really do. I think the important thing about this law as well, I think, you know, it's, you know, sometimes folks get frustrated that maybe we don't have the full compliance that we think we should have, but it is a very, very complex law. And I do know that, you know, health insurance issuers, Medicaid managed care, group health plans, they're all trying very hard to comply with the law. And I've worked with a lot of regulators in states on doing some direct enforcement work. And I think it's important to be fair and make sure that the idea is to get compliance, not to get anyone in trouble. So I think that's the sort of the mantra I try to stay with.
Thank you for that, Dr. Fowles, and thank you. It's been a tremendous resource, even for me, trying to absorb all this in. Any other comments or questions for Tim? See if there's any chat. All right. Maybe I will get this information out to you today after the meeting, so you can comb through it and digest it some more. Our next meeting is April 16th. And any agenda topics anyone wants to address for next meeting? No?
Yeah, I don't have any offhand right now.
I'm
And
loaded.
actually, Lynette, yeah, I think one thing would be good to, next time just to see if there, get anyone's perspectives on the hearing and any public comments.
Absolutely, that's a standing item on here, so we will definitely be discussing those and having some debriefing about the public comments and things like that. And I will also send out an email to the committee of when those will get posted to our website, so you can share that, and we will make sure we disseminate that information when the public comments are posted up. Anything else? Before we adjourn, let me just make sure if Director Daniels or Director Savvy want to make any comments? Anything to say before we leave?
No, I don't have anything. Thanks very much.
I just would thank Tim for sharing that important information with us. I thought it was interesting and useful. Thank you.
Well, thank you. My pleasure.
Minds are clear and if there's no other comments, we will adjourn. And we will see everyone in April. I hope everyone has a fantastic weekend and enjoy the great weather that we're going to have. Thank you for joining, everyone.
Thanks a lot, Lynette. Take care.
You too.
Thank you, everyone.